Hello everyone, my name is Jennifer Sprinks and I'm editor of Cancer Nursing Practice and also co-editor of Nursing Management Journal. Thank you for coming today. Today's discussion is on cancer care in the next decade, driving innovation. The title of today's webinar has really sprung from the discussions we had this time last year when we held our last virtual webinar for Cancer Nursing Practice. National Cancer Director Dame Callie Palmer, also Chief Executive at the Royal Marsden NHS Foundation Trust, said that devising innovations in cancer care would be the way to clear the cancer diagnosis and treatment backlog created by the pandemic. Over the past year, I've observed nurses working tirelessly to do just that. Cancer nurses are particularly passionate about using innovations to improve care and to be more efficient in their work. We've seen the development of surgical hubs, oral medicines, mobile clinics, telephone nurse-led clinics, rapid diagnostic centres and outreach work to target specific tumour sites, to name but a few. But this has been no mean feat. While trying to tackle the treatment backlog and boost diagnosis rates, you faced a crippling workforce shortage, as well as issues with staff burnout, sickness, and cases of post-traumatic stress disorder and compassion fatigue. The times have been unprecedented, so the work you've been doing has been all the more impressive. With this in mind, I wanted to ensure today's webinar would give you all a chance to feel re-energised with ideas and to feel solidarity as a workforce. Today, we will hear some of the success stories from the past year so that we can share some best practice and build on this innovative work. Our webinar will hear from leading cancer nurses in the field about how they are managing to be innovative despite the workforce challenges, but there will also be a focus on how we can use innovation in itself to tackle some of the pressures faced by staff shortages and absence. Today's session is designed to enable you to hear about innovation across the field with a view to developing these in settings across cancer care. So if I could just begin with some housekeeping, I'd like to thank the sponsors. We have Daiichi Sankyo, Gelix Oral Spray, and UCONS, the UK Oncology Nursing Society. I'd like to remind you to ask questions throughout. Please use the Q&A chat box, and we'll be moderating those and I'll be asking questions after each speaker. And there'll be a 5-minute screen break before the panel starts, the panel session. It is being recorded and a copy of the webinar will be sent to you after the event, as well as a certificate of attendance that will also be emailed to you after the event. Please do feel free to tweet away today. The hashtag will be #CancerInnovations. So this now brings me on to introducing our first keynote, and I'm delighted to say that we have Trudy Jane Geenan, who's an immuno-oncology nurse consultant at the Clatterbridge Cancer Centre. Trudy, if you could enlighten us with your talk on using innovations and the workforce to boost patient experiences and cancer outcomes. Hello, Trudy.
Hi, yeah, and thank you very much for having me as well. Yeah, so what I'm going to talk about today is how we set up a service at the Clatterbridge Cancer Centre, which the primary focus is to look after patients experiencing the immune-related adverse events associated with immunotherapy. So we'll start off by talking a bit about the side effects, and then I'll tell you about why and how we set up the service. Next slide, please. So Clatterbridge Cancer Centre is one of the UK's leading providers of non-surgical cancer treatment, and we are a unique network with 3 main cancer centres plus services across the region. We opened our flagship hospital in Liverpool in June 2020, just at the height of the pandemic. Some people might say that was slightly crazy, but we did it anyway. And we are home to the UK's first pan-tumour immuno-oncology service. Next slide, please. So this slide is just to illustrate the growth of the use of immunotherapy at Clatterbridge. So you can see in 2016 we had, very small numbers, and the treatments were just starting to emerge at this point and become, new indications were being approved and licensed. And then fast forward to last year, when you can see from the numbers that we significantly, we see about a growth of around 100 new patients each year. And we envisage that this will continue to grow. Next slide, please. Again, this is just the same. Excuse me. I'm so sorry, I do apologise, she's now going. So yeah, this slide is just again to illustrate the growth of the use of immunotherapy at Clatterbridge. Next slide, please. So immune-related adverse events, I think it's important to remember, you know, how these treatments work and why they are very different from most traditional systemic anti-cancer treatments. And while the use of immunotherapy has transformed the treatment of cancer by utilising and activating the patient's immune system to fight cancer, it has also exposed a group of immune-related adverse events that certainly as a chemotherapy nurse, I wasn't familiar with before I started working with immunotherapy. And many of these immune-related adverse events and toxicities are driven by the same mechanisms that produce the drug's therapeutic effects. Therefore, when toxicity occurs, it's as a result of an uncontrolled immune system for which there's no intrinsic control. And it's likely that patients will need to be treated with immunosuppressants, usually in the form of corticosteroids, as these toxicities rarely resolve on their own. Now, we'll talk more about this, but early recognition and intervention is paramount importance, and access to those steroids is key for patients to not only to treat their toxicity, but hopefully resolve. And next slide, please. So this slide is to illustrate, for those that aren't very familiar with immunotherapy, that in essence, if it's a living, breathing tissue, it can become inflamed by the immune system. And these conditions are, whereas they are similar to autoimmune conditions in some respect, they are driven by a completely different mechanism. And again, just to highlight that with certain immunotherapies, such as monotherapy treatments, the toxicity profile is fairly low, and around 80% of patients don't experience significant side effects, which is, I think, is a really important factor when talking about immunotherapy. And the next slide. So, how do we recognise these immune-related adverse events, and how do we manage them? So what we've done at Clatterbridge is, quite early on in the process, we developed a set of acute management guidelines for each of the most common toxicities. These protocols soon grew, and at the moment I think we have about 14 or 15 different immune-related adverse event protocols. And these involve things like how to recognise and management conditions such as colitis, hepatitis, all of the itises really. And also within those protocols, we also have a steroid tapering guidance, because we love a bit of steroid in oncology, but there's very limited guidance on how to use those steroids and how to taper them and, you know, safely wean patients off them. So that's one of the things we did quite early on. And the next slide, please. And whilst it's great to have these acute management guidelines and support staff, whether it's nurses, clinicians, in the recognition and management of these new toxicities, what happens when steroids are no longer effective for those patients? Where do we go next? And what we did next is we developed a set of subacute management guidelines, which basically guide the staff how to recognise when a toxicity is becoming static or not responding to the steroids, and what do we do next? And this includes things like, you know, tapering the steroids back up to the previous dose, considering steroid sparing immunosuppressive drugs, and also what investigations we need to carry out, things like, you know, ruling out superadded infections, you know, underlying disease etiology, to make sure that we are actually treating the appropriate thing. And next, please. Just go through these slides because these are all pretty much they're just about, you know, how we manage the these specific toxicities subacutely. If we go to the next, and the next one. And that's great, thank you. So in essence, the premise around our management guidance is that keep it simple. You know, if it's a mild toxicity, the key is to monitor and put a plan in place for if that toxicity does progress. If it's a moderate or grade 2 toxicity, and we grade our toxicities based on the CTCAE grading, as we do with most SACT side effects. And if it's a moderate, it's important that the patient is reviewed, usually medically or AMP reviewed. We usually commence oral steroids, investigate to ensure that, again, we are treating the right thing. And at this point, we'll omit the IO until we get control of that toxicity and hopefully gain resolution. And then we have our severe or life-threatening pathway, where for some patients it's appropriate to admit, but what we've done really successfully at Clatterbridge is we've developed an outpatient pathway for these patients. And again, I'll talk a bit more about that later on. Same again, investigate. And at this point, you want to have a conversation with your medical specialist, such as, you know, your gastroenterologist or your hepatologist, to ensure that the right investigations and the right treatment is in place. And it's important that at this point we consider stopping the IO, discontinuing it. But for some patients, we do consider restarting their immunotherapy once the toxicity has been resolved. And it's important that at this point as well, we consider alternative immunosuppression. We're quickly learning that the sooner we go in with steroid-sparing immunosuppression for these patients, it does have a better outcome for them. Follow-up and contact are absolutely essential, and that's, you know, the key of our service. Next slide, please. So we developed 10 principles of IO toxicity at Clatterbridge. Always take notice of vague symptoms, investigate things like fatigue, which is very different from traditional systemic anti-cancer treatments. To some extent, we kind of we accept that fatigue is a side effect, whereas in the case of immunotherapy or side effects of immuno-oncology drugs, we take fatigue as a red flag, because it can be linked to things like adrenal insufficiency and myocarditis, which is a rare side effect of immunotherapy but can happen. A blood test and a symptomatic review can rule out toxicity. And an expanded blood panel as standard should be carried out prior to each cycle. And our expanded blood panel includes things like thyroid function tests, cortisol, and glucose monitoring, because we do see cases of immunotherapy-induced diabetes as well. So it's important that we keep an eye on those glucose levels. Monitor patients and always treat the most severe parameter or toxicity. Things can change quickly with immunotherapy toxicity, and it's important that we do follow up these patients, whether it's done via a centralised immuno-oncology service, acute oncology, or the parent teams looking after those patients. Know your local and national protocols. Treat early with high-dose steroids, and if steroids aren't working, we consider adding in a steroid-sparing immunosuppression, and work with your medical specialists. And omit and potentially discontinue the immunotherapy depending on the type and grade of adverse effect. And we need to ensure that we're reporting the side effects of the management of the toxicity via the yellow card system. Next, please. So why did we need a service? And this is where we come in with what I consider to be a quite innovative way of working that we hadn't seen before at Clatterbridge. We looked at the scale of the issue and what were the main pinch points. What resources did we have and were currently using, and what could we implement easily? What reorganisation can we do? And what do we want the service to look like? And what did we need to achieve it? And how do we balance cost and demand? Next, please. So prior to the immunotherapy service, follow-up and toxicity management for patients was primarily consultant-led review every cycle, which you can imagine the burden and the impact that had on consultant clinics. Follow-up was organised in an ad hoc fashion and reliant on the role of the CNS. On the day SACT review, which quite often led to toxicities being identified when the patient was in the treatment chair, about to have their treatment, which then of course caused delays with treatment. There was centralised administration of therapies, which meant that there was no way of accommodating new treatments coming in. So how are we going to approach that? Acute management was quite often done via A&Es, and we were struggling to get our heads around the new side effects related to immunotherapy. So how did A&Es and district general hospitals manage that? Admission and prolonged inpatient stay was evident for the majority of toxicities. There was a lack of joined up care, and there were inequalities in toxicity management, what steroids patients were given and how often their bloods were monitored, things like that. And next slide, please. Oh, there was also gaps in knowledge. So what does the service look like? So the Pan-Tumors IO service at Clatterbridge is about understanding the IO horizon and creating a strategy to manage this with our senior management team. Education was one of the key elements of the service when we started it, and having a dedicated IO toxicity service within regional reach to support the acute oncology teams and the district generals throughout the region. We supported the implementation of current and new regimes through managing the capacity and flow by sending out immunotherapy treatments to the peripheral hubs and making sure that we have that capacity in centre to then support the new treatments coming through. An advisory service, and we pride ourselves on being an advisory service both regionally and nationally for people involved in immuno-oncology. And we developed IO-specific resources via our website. We have a generic immunotherapy leaflet that we've developed for our patients. We are about to launch a patient self-care app for a small group of our toxicity patients through a pilot to hopefully enable to reduce the contact we're having to make with certain patients, because some of the feedback we had from patients that during the toxicity journey they are really well, they continue to work, and sometimes it's a bit of an inconvenience for these patients. So we wanted to develop a way that patients could fill out their own assessments whilst under our care, but impacting on their life that little bit less. And what that then enables us to do is increase our activity within the service, taking on more new referrals. And the hope that we can continue to develop new ways of working so that we can make the best and utilise our current workforce, because I'm sure, as we all know, we're having significant challenges in funding for additional workforce. So how do we utilise the workforce that we've got to make things better? Next, please. An integration of the team into relevant medical specialities. So what we do is we have a link nurse within the team that is specific to a certain toxicity, so can maintain that open dialogue with our medical specialists. So how were we innovative? Well, we were at the forefront of the development of IO services, and as I've said, the first pan-tumour IO service in the UK. We are primarily nurse-led service. We were the first cancer trust in the UK to develop an infliximab pathway, and we're able to give infliximab in centre without having to refer to gastroenterologists, and that had a massive impact for our patients and certainly affected the outcome for patients experiencing colitis as a consequence of their immunotherapy. We are a primary outpatient toxicity management service. We very rarely admit patients. A majority of our grade 3-4 toxicity patients are managed as outpatients receiving IV methylpred, treatment as a day case on our day unit. We also set up a cardio-oncology clinic to support our patients suffering from, one of the rare side effects of myocarditis and pericarditis with immunotherapy. And we have different things for different medical specialities. Next one, please. So what were the aims and the objectives of the service? Well, to develop a streamlined service coordinated and managed by a team of experts. It was about collaborative working with our medical specialities so that we were able to develop our toxicity management guidelines in collaboration with those clinicians. As I've said, develop the outpatient management in the hope of avoiding admission in certain cases, and also to expedite discharge for those whom admission is necessary. Provide, as I've said, subacute toxicity management pathways, coordination of outpatient delivery and promote treatment closer to home. We also deliver immunotherapy treatments in the community at Clatterbridge as well. Improve patient experience and quality of life, that's one of the key elements of our service. And maintain an open dialogue for all involved in the care of patients receiving immunotherapy. And next, please. Keep missing that last one, don't we? So how do we manage? Nurse-led IO toxicity management ensures close monitoring of toxicities and the early recognition of potential problems. And as a result, we're able to facilitate unnecessary admissions. And as I've said, in certain cases, IV treatment therapies can be delivered in the outpatient setting under the supervision of the IO team. This reduces the length of inpatient stay for patients. And next, please. So what does the team look like? And I think this is the important, when, what we do seems quite overwhelming and quite large at Clatterbridge, but it's important to highlight that we are one of the biggest users of immunotherapy in the country. And the follow-up service is primarily led by a team of Band 6 specialist nurses under the leadership of a Band 7 service manager. Initially, in October 2018, it was myself as the lead nurse that set up the service. The team make over 800 follow-up calls each month with probably around 50 face-to-face reviews. And that's in addition to the advisory service we provide to our clinical decisions unit. And we support all the hubs and admin centres giving IO agents. And next, please. So these next two slides are just to illustrate what happens with the follow-up pathway. In essence, patients are referred into the service, and that can be from anywhere, GP surgeries, community nurses, hospice care, our own, clinics at Clatterbridge. And once the patients are referred in, they have initial contact from the team where they do an initial assessment, ensure the patients understand their steroid treatment. And then for the most part, they will be followed up twice weekly for the first 2 weeks and then weekly after that until resolution of their toxicity and they're off steroids. We do a cortisol check about 5 to 7 days after the completion of steroids to ensure that their adrenal function has returned to normal. And whilst doing this, we ensure that their cancer journey stays on track by organising follow-up appointments with their parent team. And next, please. And next, please. Again, this is just to illustrate what the team looks like. So there's myself. We have a medical oncology consultant as well, 2 Band 7 AMPs, a team of nurse specialists, and that is supported by a project support officer without whom we couldn't continue to develop these pilots and service development. We are supported by 2 IO coordinators and a clinical support worker. Next, please. Medical specialty input. So this is what I was alluding to earlier. We have a different need from each of our medical specialists. Gastroenterology is probably the service that we utilise the most. However, at the other end of the spectrum, endocrine, we've developed our own in-house endocrine management pathways, and we manage most of our patients ourselves, and we very rarely need to involve them. However, we do ensure that we maintain an open dialogue with each of our medical specialists to ensure that we're keeping up to date with current practice. And we do our very best to try and have regular meetings with them as well, whether that's, getting them all around a virtual table together or individually, things like we have an ILD MDT to manage our pneumonitis patients. We have a weekly cardiology MDT. And next, please. Again, this slide is just to illustrate the different medical specialists that we work with, and it's enabled us to have things like rapid access to investigations such as tissue biopsies and flexi-sigs, and also to develop our infliximab pathway. And next, please. So how do we measure ourselves, and how do we know that you know, our innovative way of working has achieved what we wanted to? So we set ourselves some key performance indicators, and those were to reduce admission rates at the centre for patients experiencing toxicity. Also, we wanted to reduce the number of patients experiencing those grade 3-4 severe and life-threatening toxicities, because for those patients, it's, you know, the resolution of that toxicity is easier if we prevent them getting to that level. How could we save bed days? You know, were we able to save bed days for the trust? And also, we wanted to look at our outpatient activity and increase the numbers of patients that we were taking under the service, and also increase the number of referrals to Clatterbridge in the community, which meant that we were able to make availability for treatments to be then given in centre as we were transferring these patients out to the community. And next one, please. Also, we wanted to make sure that the patient experience was maintained throughout, and patients are generally whilst receiving treatment, and they also, you know, even during their toxicity journey, the majority of our patients are well. In fact, we can have patients with a grade 3 hepatitis that are completely asymptomatic and feel really well. And next, please. Again, these are just some of the things that were highlighted by our patients in the early days of the service. We wanted to find out, were they getting benefit from it, and was it working for them? And next one, please. So this is just, so we looked at the patient journey pre and post the service, and this slide is just to simply illustrate the fact that by implementing the service, we were able to, for a patient experiencing colitis, in essence, we were able to halve the time to resolution of symptoms by 50% for these patients, and that was by having the rapid access to flexi-sigs, being able to give infliximab in centre, and as a result, we were able to, even in the case of a grade 3 colitis, we were able to get resolution of that toxicity, and then patients were able to continue with their immunotherapy without further complication. And next, please. So this is were we effective? So what we did was we did a comparison of the first 18 months of the service and compared it to prior to that. And what we were able to do is we were able to reduce admission rates due to toxicity by 40%. We reduced the incidence of those grade 3-4 toxicities by 30%, and that was purely through the close monitoring of those grade 2 and grade 1 toxicities to ensure they didn't progress. We increased case activity and nurse-led outpatient management of toxicity, which promotes additional funding. Well, prior to the pandemic, it did. We reduced the total number of bed days occupied due to toxicity by 17%, which resulted in a saving of £62,000. And we also reduced the burden on tumour site-specific outpatient clinics. And the next one, please. Sorry, so the next 3 slides are basically just graphs to illustrate those outcomes that we had for our patients. And I think that takes us to the end, and I'm happy to take any questions.
Great, thank you so much, Trudy. That was really, really insightful, and I can see some significant outcomes there through your service. Now, we've had lots of questions, so
I've just noticed.
Yeah, so I'll kick off with it then. And for some people, this will be a completely new area. We've got a lot of different attendees. So first question is, how effective is immunotherapy, and will that be the main point of treatment in the future?
Okay, so this is a really interesting question, and usually I do like to include a slide to go back to where we began. So in essence, a patient in in the early 2000s, up to 2011, a metastatic melanoma patient had a prognosis of around 7 to 8 months. Even with the use, using chemotherapy, those patients, they had a response rate of about 5%. With the introduction of combination immunotherapy 7.5 years ago, we know that now, even to this day, around 49% of those patients are still alive, and we've seen around 20% complete remission for those patients. So yes, these drugs do work. They've completely changed the landscape for a lot of patients. And even within the lung cancer cohort, we don't see the same responses with regards to remission, but it is extending patients' lives by years. At the moment, there's about 40 different indications, certainly at Clatterbridge, for immunotherapy, and I don't see that reducing anytime soon. There are still a group of cancers that don't seem to respond to the immune system the way that others do, and there's further work going on to try and figure out why that is. We've predicted at Clatterbridge that by our usage is around 10-11% of overall SAC delivery at the moment, and we've anticipated by 2025 we're going to be looking at a quarter of all treatments will be immunotherapy based. So I hope that answers your question.
Great, thank you. And of course, you were talking about immuno-oncology when you put the acronym IO. Are your protocols the same as the UKON's guidelines?
They are very similar. And if I remember rightly, most of the protocols were in development before I started. And I think the UKON's guidelines, they were based around our guidelines, so they are very similar. I think the difference is that maybe we review our protocols on a yearly basis, and what we do is we adapt those protocols in accordance to our current practice. So that might be where the differences are, but they are very similar.
Okay, thank you. And you talked about fatigue being one of the worrying red flag side effects. Do you have a specific protocol to assess the immuno-oncology for fatigue?
So it's currently in being written as we speak. So what we do is at baseline, we do a fatigue profile on all patients about to receive immunotherapy, and that looks at things like iron profiles, vitamin levels, and it has two elements to it. One is to try and optimize those patients. We're very, prehab is a very prevalent thing at the moment. How can we increase the patient's ability to tolerate treatment better? So we do it from that point of view. We also did it because we were identifying patients with iron deficiency anemia during treatment, and we wanted to identify, was it as a consequence of the activation of the immune system, or was it an underlying condition? Again, if patients present with fatigue, we do a fatigue profile to see if there's anything that we can replace with regards to hormone levels, vitamins. But we also know that in myocarditis patients, there's a large correlation between fatigue. So we will do things like cardiac profiles on those patients as well, looking at their cardiac enzymes and any markers for heart failure. If we've ruled all of those things out, we work with our occupational therapy teams to see if there's ways that we can support those patients in managing fatigue, because we also know there's a number of patients that simply because we've overstimulated their immune system for so long that they get tired, and it's about trying to support them with that.
Great, thank you. What glucose monitoring do you carry out when commencing patients on steroids?
So as baseline, we do a HbA1c in all our patients starting immunotherapy to try and predict if they're pre-diabetic or at risk of developing diabetes. We then repeat that before they're started on steroids as well, and we monitor their glucose levels as part of their blood monitoring. We're doing some work around the fact that if we can facilitate for patients that we consider to be at risk, can we facilitate them with blood glucose monitoring, finger prick monitoring tests themselves? And that's something that we're looking at. But what we need to do is we need to look at the data and see how many patients we have induced steroid in diabetes with the use of steroids.
Great, thank you. I've got a couple of questions here that are slightly similar. It's about sharing. Are you prepared to share the app you were about to pilot and the patient information leaflet via email?
So I wouldn't be able to share the app just yet because obviously it's a pilot. But once it's going to be a 12-month pilot. I can tell you that it's working with a company called Docabo, and it's a very good app. But of course, when we've finalised the pilot and we've got the outcomes, I will share it with everyone. The information leaflet, yes, more than happy to share that. It is also, I think we've made it available on our website, but again, I'm happy to share that.
Great, thank you. Last question then. Does your service only include patients on immunotherapy, or do you also follow up patients after treatment with late effects?
So yes, we do. About 12 months ago, I set up a late effects service with twofold to that as well. Patients who have ongoing side effects from their immunotherapy that have been under our service for a while but need less regular monitoring or have stable toxicity but are still experiencing side effects, they will come to that clinic. And also patients who develop side effects post immunotherapy, which we all know can occur for several years after finishing treatment. So yeah, we've been doing that for about a year now. What we're trying to do at the moment is tease out the two different things, because I want to try and focus on the presentation of late effects after finishing treatment. So it's a really interesting piece of work, and I'm excited to see what the outcomes are.
It sounds like very interesting work. And I mean, I just wondered whether some of the challenges of this will be maintaining the sustainability of it and keeping it going, or do you think it'll be the cost effectiveness?
I think it will be a bit of both, really. I don't think I had this conversation with someone at UConns the other week that, when we started out in this process working with immunotherapy, I don't think anyone had a real understanding of the fact that it was going to be as successful as it was, and that we were going to prolong people's lives. It's all around cancer survivorship, isn't it? And the impact that because for most treatments, they would be have surveillance, every few months, after they finish treatment, and then be discharged from oncology. Whereas we can't do that with these patients. We've got a responsibility to monitor them after they've finished their treatment and ensure that we are picking up on any side effects. I think in the long term it will be cost effective, but the process of getting to that point is going to be a real challenge, and I'm in the process of writing business case number 4, so to try and increase our workforce, because you can only do so much, but I think we have a responsibility to ensure that we provide services to follow these patients up.
Great, thanks very much, Trudy. That's all we have time for, but thank you so much for your presentation, and also to your dog for its cameo role.
Oh, that was
Brilliant.
such bad timing. I'd just like to say that, if anyone does have any questions afterwards, that I'm happy for people to email me, and, with any queries.
Great, thank you so much, Trudy. Thank you. Now, I'm delighted to move on to our second keynote, and we have Mark Fulks, who's not only president of the UK Oncology Nursing Society, but he's also Macmillan lead cancer nurse and nurse consultant in acute oncology at the Royal Berkshire NHS Foundation Trust. And he's going to be talking to us about a big topic of addressing workforce challenges. Good luck, Mark. Big topic. Thank you.
well, I'll certainly give it my best shot. Thanks for inviting me. It's always a pleasure to talk to such a sort of large group of people, cancer nurses largely, I suspect. So it's really good to be here, and thanks for the invitation. To clarify, I am indeed Mark Fulks. I am the president of UConns, and I still work clinically for part of my job in our acute oncology service here at the Royal Berks in Reading. And I really enjoyed the first presentation. Really good, and now for something, as they say, completely different. So can I have my first slide, please? So in interest of being transparent, I've got no financial interest to declare. I'm not receiving no payment for this presentation, but as president of the UK Oncology Nursing Society, I do work with a large number of industry partners, and I don't derive any financial benefit from that, but UCONS does. And I'm sure our partners would be thrilled if you checked out who they were by looking at our website if you felt the urge. Next slide, please. Okay, so what I'm going to talk about today. So I'm going to talk about workforce. I'm going to talk about workforce both pre and post COVID and try and sort of get a bit of a debate going really. So feel free to do your keyboard warrior stuff in the chat and send some questions to me. I'll be really happy to try my best to answer those, even if there might not be an obvious answer. So what I'm not going to talk about, can I have the next section, please? I'm not going to talk about technology and AI. I'm not going to talk about technology and AI for a couple of reasons. One, that I'm really not qualified to do so, and there's lots of people who have lots of feelings and better able to present than me on that subject. But the other thing about that is that I think it's often overcooked as a solution to all of our nursing problems. I think that there are some elements of AI and technology that are really useful. I think that it should only really work for nursing when it serves us and when we don't end up serving it. So I'm not a big fan of replacing our hospitals with apps, to be honest, as I think that detracts from the nursing value. The other thing I'm not going to talk about is I'm not going to talk about skill mixing downwards. I'm really happy to have innovative roles in oncology, but I do value the presence and the value that qualified cancer nurses bring, and therefore I do not see that skill mixing downwards as a long-term strategy will help either us or our patients. More importantly, I think it could become a bit of a race to the bottom. So that's why I'm not going to talk about that, as I don't believe it. So there's a couple of issues there. So I'm going to try and define the problem, and I'm sure that many of you on this meeting have had experience of this problem. I'm sure many of you are living it every day. So I'll just try to summarise that a little bit. I'm going to talk about what I think might be some of the solutions. There might not be solutions. There might be ways of thinking about solutions. I'm going to talk about how we might increase the profile of cancer nursing. It's my particular interest, I suppose. I'm going to talk a little bit about the Ascend project, which some of you might have heard of, which is a massive project which is trying to restructure cancer nursing careers. And sort of not just cancer nursing, sort of allied health professionals, really, all the way through cancer, so people have a much clearer path, a bit of a Google map, if you like, through sort of cancer careers. And I think that will really help us. And I'm going to talk a little bit about how we might retain our current staff and do something about our ageing workforce, of which, despite my youthful good looks, I am definitely part. And then I'm going to try and come to some conclusions. So I hope that's okay with you. So next slide, please. So I'm going to try and define where we are sort of pre-COVID, really. So in the UK, we've currently got about, probably worse than that now, but we've probably got about 39,000 registered nursing vacancies. So it's about 12% increase from March 21. But of course, this is nothing new. Workforce issues were already looming back in 2016, which Macmillan neatly outlined for us in their census that was put out at that time. So sort of we were definitely cancer nursing workforce was approaching the crisis pre-2020, but certainly COVID has focused this, I think. So cancer nursing in the UK has particular issues, I think, with shortages of trained chemotherapy nurses and an aging workforce of clinical nurse specialists, and that we're running at a rate across the UK of about 40 in some areas, including my own here. We're running harder than that. So a lot of our clinical nurse specialists are going to retire in the next 10 years, and my concern is there'll be fewer people to replace them. Sort of back in 2017, seems a long time ago now, but some areas of the UK had vacancies of a rates of about 15%, and this is likely to have deteriorated. That's specific to cancer care. In sort of 37%, as I said, specialist cancer nurses were older than 50 years, not 50%, and likely to retire within the following 10 years, and that's certainly won't have got any better in the last sort of intervening years. So, despite policy initiatives, pretty much all of cancer care takes place in or is managed by secondary care. And I should say that I don't think that's necessarily the best thing to happen. I mean, even though I work in secondary care, I didn't necessarily expect when I was a young cancer nurse to expect to end my career working as a nurse consultant in the acute trust. I thought maybe that there would be more services moved out into sort of primary care and into the community by then, but that hasn't happened for a whole range of problems. I suspect mainly because primary care hasn't got the workforce to do it currently, and it's also a problem around how that's paid for and about the financing of that. So that's an interesting argument. I'd be good to hear your views on that. So that's the problem. That's where we were pre-COVID. So if we move to the next slide, please. So you can click through this if you wish. So what has happened since COVID? I'm sure you're all living the dream out there, but certainly the COVID pandemic has increased the rate of attrition, and already it's forced nurses out of the profession. It's certainly for some nurses who were contemplating retirement into a state where they're becoming much more certain about that they want to retire. I think there's a clear sense of moral injury from the events of the pandemic, and that doesn't exist just outside of cancer nursing. I think there's a very clear sense of that within cancer nursing. And the question I want to ask is, can you clap for the heroes in the cancer pandemic and then in the next breath, in the next year, not pay them a reasonable wage? And I think we're with the recent sort of strike action, the government and NHS are wreaking the whirlwind there. They're harvesting things that passed because these things haven't been addressed. There's a backdrop of challenges with treating now high numbers of cancer patients related to delays in the pandemic, and that's not just that's around sort of diagnostic delays and also a backlog of people who delayed presentation. I'm sure we're seeing some of that. Certainly I see that in my acute oncology service, which I work in currently, and we've not stopped sort of increasing numbers of people living with cancer. People are living longer with cancer, and the effects of treatment, and sort of many people are living with that, and how are they going to be supported if we're not doing it? So these are all questions, and I think I was speaking to Claire earlier before when we were about to start about precision medicine and genomics, and I think it will increase the need for expert nursing and advice and support. And I said glibly that it would be the salvation of cancer nursing, and I believe that, and that's not just to be saved from ourselves, but because I think this will provide us with a real opportunity to build our skills. So it's interesting to hear Trudy's presentation first off. I think that fits very clearly within this. Next slide, please. So what can we do? And I think the first thing that we can do is to have a look at the status of cancer nursing. I think in the UK, genuinely, cancer nursing has a high status with the public, and I think it's particularly true in those who have experienced a cancer diagnosis either in person or with their family. So if you have direct experience of cancer, then the value of cancer nursing is pretty clear to those people who have a direct experience of it. And I think that there is a lack of understanding outside of that direct group that how important cancer nurses are to keep the whole system going, and particularly to maintain the patient experience. I think that we can see the value in which the public placed cancer nursing by during the pandemic, and nursing generally, actually, the number of people who volunteered to train to be nurses, and I think we've lost a lot of that momentum, sadly. But I think there is a real clear belief in the public, if we can tap it, that nursing is a valuable thing to do, and within that, cancer nursing is particularly a valuable thing to do. So I think that's true. I don't think that status, though, is particularly reflected in government policy, where there's a sort of increasing emphasis, I think, for sort of like new hospitals program, new drugs, which are, there's nothing wrong with new drugs and technology and kit, but unless you have people to give the drugs, unless you have people to drive the kit and work in the new hospitals, there's very little point in making these investments, because workforce is a key challenge, and I think that's not really been addressed, or it's been addressed poorly. You can see that I was asked to present at the Select Committee on COVID recovery and cancer, a select committee chaired by Jeremy Hunt, actually, ironically, who found that that it was a very poor. There was very poor government record on sort of investment post-COVID in cancer services, and that's absolutely shown. I think that continues. So, and it should be mentioned that in that report, specialist cancer nursing was specifically mentioned in an area which required investment, and I think that we've not really seen that investment as yet. So how do we shift the perspective? Well, I think we should celebrate nursing's success. I mean, I think we need to continue on the strength of public feeling. So like I said, we had a 32% increase in application of nursing degrees after the pandemic. I think people do value nursing, and I think we need to try and, as cancer nurses, shift the perspective towards ourselves. I think we need to link the best of care with nursing. There's, like I say, there's no point in new hospitals if you don't have skilled staff to work in them. And I think there's been a number of high profile sort of nursing disasters, really, with people who have abused their position over the last 2 or 3 years, or sort of recently. But I think the majority of people believe, and I think the majority of the British public believe that nurses are to be trusted, and I think that we need to build on that, because I think the British public do really believe that. Next slide, please. Okay, so the next thing I'm going to talk about is something that's close to my heart, which is the Ascend programme, which is a sort of massive, sort of multi-factored, sort of multi-collaborative approach between Health Education England. Even though it's hosted by Health Education England, it's a Four Nations sort of initiative, ourselves in UConn, Macmillan, and lots of other partners, RCN, lots of other partners involved in this work, in order to try and build a sort of clearer pathway. And if we look back to 2020, Macmillan, in their Addressing the Gap document, did actually highlight that structured pathways would support nurses to pursue a career in cancer care and help secure their future workforce. And the other thing that I feel very strongly about, and it would be also good to hear your view on this, that more content on caring for people living with cancer should appear in the undergraduate curriculum, and that's actually more difficult to bring about than you might think. So I think we just need to bring the whole debate about cancer nurse recruitment forward into schools of nursing, into universities, in order that we do our best work to recruit these people. Next slide. So this is a right old technical slide, but it sort of outlines the structure of the programme. So basically, we've actually got sort of six different work streams, really, starting with cancer support workers and framework for cancer support workers, going through to pre-registration, trying to build, as I said, more cancer specific and nursing education is pre-registration, and then you've got the particular part of the Ascend programme where I've been working myself. Verna Lavender and Ruth Hammond works in the independent sector, have been working hard to sort of build the framework for people who are newly registered, and then moving on to sort of enhanced sort of level of nursing, so people who are registered and starting to specialise, and we're pleased to say that we're very close to commissioning a qualification in speciality, which hopefully will be with you in the next sort of few months, which will be a kind of recreation and modernisation of the sort of EMB 237 type course, which will provide a clear sort of, if you like, a gate where that little certificate is, to when you're working at an enhanced level, to show your intent to add it sort of as career in cancer, and that won't be nursing specific, that will be across a whole range of allied health professionals. After that, then we've got sort of 3A and 3B, which is our people are moving from enhanced to advanced levels of practice, and that would be specifically targeted at people who are sort of junior CNSs, senior CNSs, AMPs, and then following that, we've got consultant and strategic level practice sort of leading sort for strategy and having a national voice and leadership. So, and I think that all of those things are important, and we're trying to link them up. And you can see the partners we have at the top of the screen there. We actually have more partners than that, but it's a very big and exciting piece of work. The other thing is that underpinning all of this, and I think Diane, who will be on the panel later, has quite a lot to do with these with the frameworks in cancer nursing, as well as Vanessa, but also there's an education, there's a sort of capability framework which is going to be published in January, which underpins all of this work. So it's a very specific bringing together, because there's actually two badged sort of competency frameworks at the minute, youth badged competency frameworks, and this will hopefully bring them all together into one place, which I think will be useful. So yeah, it's a big old project, and I think that hopefully many of you might have been asked to attend sort of workforce sort of groups, and this work will continue certainly for the next 2 or 3 years as we build a sort of all these work streams into practice and come up with commissions and education. There's going to be a sort of hub, an online hub where you can find all this information, which is already started to be built. We already have some information, so it's a big and exciting project, and I hope it will make a big difference to you. Next slide, please. Okay, so I'm moving on to retaining the current workforce. So I think there should be some relatively easy wins here. I mean, there are others that are obviously more difficult, but I think the first thing we can do, and I think generally we've been pretty poor at doing this, certainly from a government strategy point of view, but to repair the sense of moral injury experienced by many cancer nurses during the pandemic, and that was around sort of people who were moved out of their current out of their jobs, felt that they were valued, moved to sort of more acute areas of which they had very little experience and skill, and sort of their service was often suspended. So there's a real sense of injustice, I think, as well as all the national problems with things like PPE and those sort of environment we found ourselves working. So I think we need to build and develop a mental health support, and I know Matt Millen has done a huge amount to support this work, and many trusts have too. Just need to keep that going. That what was done during the pandemic needs to continue and to be business as usual, I suppose, but looking after our people. And I think I was speaking to Eamon Sullivan last week, who was the sort of lead nurse in charge of the Nightingale hospitals, and one of the things he said was one of their key objectives when building certainly the nursing teams for those Nightingale hospitals was to treat the nurses like rock stars. And I think that people need to be able to feel that. They need to be able to feel that they're really special when they're working, and I'm not sure that always comes across at the moment. So yeah, that'd be really good. And there should be an acknowledgement of the mistakes made and some sort of redress on those issues. Obviously, I feel very strongly that we need to improve paying conditions for our existing workforce. I mean, I think we're in a position where we've got industrial action. Certainly myself personally I would never not support somebody who made that choice. And I think that's how I vote as my own business, but I think you can probably guess. But I think that obviously I've already said that we need to resist skill mixing downwards. I don't think that this is going to help us in the long term, and we need to be very clear about what nursing is and what qualified nurses, cancer nurses, bring to the table. That I think is a significant amount. I think we need to acknowledge that technology doesn't fix all of our issues. It's particularly true in nursing. I think nursing is a job that relies on building personal interactions with people and personal and people should trust you. And I think it's really hard to do that via lots of media, via the telephone or even by video. Although video's better, I think there's some real challenges for us that we should. And I've just been looking through my cancer patient experience comments last week as I present to our board, and part of that was showing that there was certainly in my comments there was quite a lot of growing disquiet from patients around not having face-to-face consultations. So we can try and prove to ourselves that it's a really good thing to do as healthcare professionals, but we need to be able to bring people with us, and people need to believe that. We need to build the evidence for it. So before we commit to that. And I think we just need to be flexible. I think we need to be flexible with older nurses. I mean, it's starting to change a little bit, but why would we let people with all that experience just walk out the door without making them an offer? If people want to come and work like a few hours a week, they should be allowed to do it, and we should be able to offer that flexibility. I really believe that. I think that many people would like to do it, but it needs to be down to them and what they want to do. We should make them an offer. Next slide, please. So in conclusion, I think I would say that cancer nursing in the UK is currently experiencing a perfect storm, and it's not just us. Well, this is happening all the way across Europe, but I think that we've had such a highly developed sense of sort of cancer nursing expertise, and we've built such an expertise base in the UK. I think that we feel it very acutely when that starts to deteriorate, and I really wouldn't want to see that happen. So I think that there's been a lack of long-term investment in cancer care, cancer nursing specifically. There's been we've still got a large backlog of patients who require treatment, and I'm sure you're experiencing that. Many of you are experiencing that every day. We've got an aging workforce, and we've got a sense of moral injury and fatigue from the pandemic that is very present. But I do believe that we can regain control. We can regain control with strong and focused nursing leadership. And I know that I take my role in this quite seriously. I know that Claire does too, who's on the call later, that we can provide that kind of leadership. We can help for cancer nurses to find their voice and force a political will to change, if you like. I think often we're just too nice. I think we're nice people who look after people, but instead sometimes we just need be a bit tougher. We need to be able to develop the end-to-end structure from pre-reg courses to senior strategic levels, and I think the Ascend project will do that if we get it right. I don't know if we are going to get it right yet, but we're working very hard to do so, and I think that structure will be in place. We all need to be able to retain and develop staff we already have in place in order to be successful at that. Next slide. So that's some references, and I'm sure Claire will be pleased to see lots of Macmillan references on there. Next slide. You can please put your questions in chat. Thanks for listening to me go on. Apologies if you've heard me go on in this way before, but I think it's an important message to reiterate. You can contact me. Please do contact me at these addresses, and you can and you can certainly hit me up, as the young people probably never say, on Twitter by contact me on the weird _worm. It's a long story, but you can certainly find me there, and also go to our UConn's Twitter, which is very active. So thank you for your attention.
Thank you, Mark. That's really open and candid presentation, and it's also good to see some positives in there for cancer nurses. There are workforce challenges, but with a shift in perspective and focus on the Ascend programme, hopefully with some flexibility we can address some of those. We have got some questions here for you. Would you encourage recruitment of non-specialist nurses into clinical nurse specialist roles to be trained on the job, especially if they have valid surgical nursing experience of the cancer specialism but no oncology experience?
Oh, okay, that's a really good question. I think I would support that, provided the structure was in place to do it. What I don't think should happen is that people should be put into very senior positions, band 7 roles, in order to do that. And I don't also think that people should be recruited as sort of CNSs at band 5 either. I think if people are going to develop, they should be paid adequately. I think where I think in my own place of work that we would recruit surgical nurses with some experience of cancer into developmental CNS roles. I think that we need to develop those skills. You can do those on the job and via apprenticeship schemes and things like that, and we need to develop those. But I wouldn't be against that. I think what is important is that we pay people adequately, support them adequately, and we train them adequately in order to do the job. I think what might happen if you do that is that people feel completely overwhelmed by it and are not successful. So I think it's all about the structure that you have in place, and many places do already have this structure. I think there'll be pressure. I think there'll be pressure to downgrade CNS roles. I think there's already pressure in some places to pay people sort of band 6 for clinical and specialist roles, which I fundamentally disagree with. But you know, I think development's fine.
Great, thank you. And this is the Macmillan question. Hasn't Macmillan set up a 2-year training scheme to train registered nurses to be clinical nurse specialists?
I think there's apprenticeship schemes, and there is certainly an apprenticeship scheme, a very good one in the north of England. I think it's Northern Cancer Alliance are doing that kind of work where that's in place, and I think that will be good. We have to be more creative, and these sorts of schemes will fit very well with the Ascend program. We need to take them into account, and I think there are, where we do build good programs, that would be really good to have apprenticeship schemes running alongside it. What I really believe in, and what I think many people would like to see as where a lot of this training takes place on the job and on placement, and people are given the opportunity to develop. And I think there's been a move away from that recently. I'd really like to see that reinstated.
Great, thank you. I've also got another question actually from Diana Greenfield, who's speaking.
Oh, hi, Diana.
Can you see in the future a pre-registration course specifically for registered nurses in cancer nursing?
Oh, that'd be great, wouldn't it? Well, I can see how would that fit with registration, but yeah, I'd really like to see it in a way that you would train to be a psychiatric nurse or train to be a paediatric. It'd be really good. So it's a great idea that we could develop a specific registered part of the register for cancer nurses. That'd be amazing. I think we're some way off that. Actually, I think it'd be really good. Our first step should be to get more cancer in the general curriculum, and as I said, I think that's been really tricky. You speak to maybe some people on the meeting who work in cancer education, they've already got a packed agenda. So I think what we can do is be more creative about sort of having shorter modules and things like that, which provides sort of nurses in training with indeed other health professionals in training with something specific they can carry on as well as their registration. So I think that'd be really good to have specific courses. So that would be a good first step.
Great, thank you. And I think I know the answer to this, but as a manager, do you work on the floor when required to help your staff? And this would help staff morale when short-staffed.
I absolutely do. Yeah, I mean, I think that I would be. I don't think anybody wants me working on a ward. I don't think anybody wants me doing the drug round, because I'm pretty long in the tooth. I haven't done that for a while, and I don't really like that idea that when times get hard, sort of specialist nurses can drop what they're doing and go and work on the ward. Don't like that. They have got other jobs to do. But I think that I would definitely and do frequently step up clinically to support colleagues, and I will continue to do that as long as it's within my skill set. Yeah, absolutely. And I think many of us would hope that we lead by example.
Okay, thank you. Can you explain a bit more as to why skill mixing downwards is something to be resisted? Why would we want to downskill?
Why would we want to downskill? Well, I think there's.
Why wouldn't we want to?
Why wouldn't we want to?
Yeah.
Because I think that if you believe, and I really do believe in the skills that registered nurses have, And I think it's actually summed up by quite a lot of research. There's lots of literature and lots of research about how, for example, specialist cancer nurses improve the experience of people with cancer. I mean, in many studies, it's turned out to be the one factor, actually the main factor that improves people's quality of life. And I think that if we believe that qualified nurses are bring something that's, and I think that nursing is, particularly cancer nursing, is a safety critical profession. If you start to take unqualified people and non-registered people into that pathway into key roles, then you begin to water that down, and it's not a solution. All it does is provide worse care. I don't think it's a long-term solution. And that's not to say that I can't find ways to incorporate non-registered people into a pathway. For example, our sort of cancer Macmillan sponsored cancer support workers here are really good, and they support the work of the CNSs, and they set up holistic needs assessments, and they help our specialist nurses, but they don't do the H&As. They set them up so other people can do them, qualified and registered staff. So I think it's very easy to say, oh, I know why these roles that cancer nurses do can be devalued, and sort of anybody could do these, can't they? Well, I believe they really can't and shouldn't, because it will end up with a reduction in patient safety. I really believe that. It's not something I'm making up. I think the evidence would back it up.
I think it comes back to what you were saying earlier, shifting that perspective and raising the profile and status of cancer nursing, and taking pride, I suppose, in the specialism that you have there.
Yeah, absolutely. Absolutely believe that.
Yeah. There's another question. There seems to be a great variation across the country regarding banding of specialist nurses. What do you see as the appropriate banding for trained clinical nurse specialists, and do you think this should be standardised?
Yes, it'd be really good if it was standardised. I think that there will always be downward pressure from trusts, employing trusts. A lot of trusts will want to pay, because you see in this workforce, a lot of people would see them as a massive overhead. They're senior nurses. There's a lot of them in many places, and they cost a lot of money. I would say they're really good value for money, but there's definitely pressure to sort of pay those people less. And I think that I think it also depends on what role they're doing. If people, and most of the CNSs that I know are working at, they're working at an advanced level. I think what can happen, that some of the advanced nursing roles that CNSs do, such as holistic care, such as delivery of good communication, can be undervalued when placed next to things like tasks, like putting drains in, doing minor operations. And I don't believe that. I think those are equal, or certainly I would think that holistic nursing skills should be valued. So I think it'd be really good to see that standardized. Whether we're able to bring that about as a real thing, I don't know. It's hard to control what individual providers do, but I think it'd be good to get guidance, and hopefully one of the things that will fall out of the Ascend program is to get that clear, because there's also a big debate raging. Anybody who goes on Twitter for any length of time will find sort of the big debate that goes on about clinical nurse specialists and advanced practice. It's not easy it's not difficult to find that argument.
I agree. Just one question that was slightly different to the others. I imagine it was for you. It's with regard to chemotherapy nurses. What is your evaluation on the role of SAT workbook?
Oh, okay.
Something Econs deals with.
Yeah, well, the SAT workbook is something that, the Econs SAT workbook is something that's been very well appraised. I think it provides a passport sort of standard that people can transfer, so I think it's immensely valuable, and we're in the process of making that digital at the minute. So that's a big project that in another part of my job I'm involved with, we've already started that work, so people can, instead of having it on a bit of paper or having it in a clunky old PDF, you can carry your passport around with you, your competency passport in delivering SAT, on an app on your phone or on your PC. So I think all of that is really valuable. I think any sort of competency document that's transferable is valuable, particularly, and I believe the Econs SAT passport is being updated and it's gold standard. That's not to say that it's by itself is a teaching thing. It's not like it's a framework. It doesn't provide in itself teaching. It should be backed up by education. But as a competency framework, I think it's really valuable. But then I suppose I might say that, being the president of Econs.
Great,
You
thank
can
you,
take
Mark.
that with a pinch of salt if you like, but I think it's been proved in practice.
Brilliant. Just one quick question for me before we take a 5-minute break, just to make it really tangible for the audience. What do you think nurses could take away as a simple thing they can do that's cost effective starting tomorrow to address workforce issues? How can they try and ease the workforce pressures on them?
Oh, okay. Well, I think, well, there's, oh God, that's really tricky. Thanks.
It is just one simple thing that they could
Well,
start
I think
tomorrow.
look after themselves. I would say look after themselves. Don't overwork yourself. Use sort of mental health. It is sort of things that are in place. Use the Macmillan Hub. There's all sorts of ways to look after yourself. So I would say try for once, and there will be many people who don't do this on this meeting. Look after yourselves for a bit. Yeah,
Brilliant.
that would be my one thing.
That's a great way to end. Thank you very much, Mark, for your time today.
Well, it's been a pleasure. I'll hang around.
Brilliant, thank you. I'm glad. And thank you so much for joining us for the first part. We're just going to take a 5-minute break. Do keep putting your questions in the Q&A box. So we'll have a take a 5-minute break now and back at 1:20. See you soon. Thank you.
Thank you.
Hello everyone, welcome back to today's event on cancer care in the next decade and driving innovations. This leads us on to the panel discussion, and we're going to be looking at driving innovation in times of change and uncertainty, how are nurses responding to the challenges and enhancing patient care. So we have 3 great speakers. We have Professor Diana Greenfield, who's a consultant nurse and MDT lead late effects at Specialised Cancer Services at Sheffield Teaching Hospitals NHS Foundation Trust. We have Dr. Claire Taylor, MBE, who's Chief Nursing Officer for Macmillan Cancer Support and also Macmillan Consultant Nurse at St Mark's Hospital Foundation, and also Emma Harnett, who's not only a cancer survivor, but she's recently winner of the RCN Nursing Awards Team of the Year category, and she's her team won for the One Step at a Time initiative, which she'll be telling you more about today. She's part of the Hertfordshire and West Essex clinical commissioning group. So on to our panel discussion. If we could start, please, with Claire Taylor, that'd be great. Hello, Claire.
Hi, everybody. It's lovely to be part of the panel today. And I'm looking forward to discussing innovations in cancer nursing and the access to trials and also patient experience.
Great, thank you. And if we could also go to Diana. Diana, are you there? Thank you.
Yes, I'm here. Hi. Hi, everyone. Yes, I'm equally excited to be part of this panel discussion and looking forward to the discussion.
Brilliant, thank you. Emma, would you like to tell us a little bit about how you won the One Step at a Time initiative for the Team of the Year category, please?
Yes, thank you. Thanks for having me here today. So I'm Emma Harnett. I'm a Macmillan primary care nurse facilitator working in West Essex. I came to post in March of 2019. And a week after I was lucky enough to get the role of Macmillan Primary Care Facilitator, I was actually diagnosed with cancer. So you couldn't write it. Well, I did actually, because that's why I'm here today. But, you know, it's really to say cancer has no respect for age, gender or ethnicity. It really doesn't matter who you are or what you do. You know, nothing can prepare you for being diagnosed with cancer. It is a real shock. You do wonder, you know, how are you going to tell your family and your friends? And I think not even my 30 years experience as a nurse could prepare me for that news. However, coming back into the role the year after being diagnosed with cancer, as you can imagine, was very challenging. But also I had new perspective, a completely different perspective than I might otherwise have had working in the role. I wasn't previously a cancer nurse specialist. The role didn't require me to be that, but my experience really is primary care. So I worked for many years as a practice nurse, as a lead practice nurse in primary care. So with this new perspective, I had this idea. A lot of the information that's given out at diagnosis it is great. Obviously, it's essential for patients to have that. But it's very clinical in nature. And for me, obviously, being a clinician, I understood some of the terminology. But for a lot of patients and a lot of people, you know, whose perhaps first language isn't English, you know, it's very challenging. So we had this idea. I met with the patient panel lead at Princess Alexandra Hospital and the patient engagement lead, and the three of us came up with an idea. And it was simple: cancer information by patients, for patients, professionally produced. So we have formed a team, and that team is a number of lived experience cancer patients, Macmillan professionals, clinical nurse specialists from the trust, and together we have a team, and we're called One Step at a Time. And the reason why we're called One Step at a Time is because when you're faced with cancer, that's all you can do, is literally take one step, or one day at a time. So we entered into the Royal College of Nursing Team of the Year, and we were absolutely over the moon and delighted to win the award just a month ago, and attended the fantastic awards at the RCN headquarters. It means everything to us because, you know, me as a lived experience partner and as a Macmillan professional and as a nurse, you know, I felt that I had this duty to share those experiences and really understand and be able to help our patients going through their cancer pathway within West Essex. But it's not just about sharing it within our locality, it's about sharing it whoever is willing and wants to hear about our initiative. And we have shared with the Cancer Alliance in the East of England and many other organisations. And I was really interested to hear what Mark was saying about workforce, because the other 3 days a week I work as the Suffolk and North East Essex Clinical Education Lead, and we do workforce development. So we've actually used our initiative to bring to the students at the universities, and in my Macmillan role, really just talking about cancer information and cancer care reviews to help empower and help our workforce within West Essex, our nursing workforce, so that patients will receive hopefully better care and more joined up care between primary and secondary care. So thank you.
That's brilliant. Thanks so much, Emma. I just thought it important that people knew a little bit about your initiative and why we've asked you today, and they can put some great questions to you. So we are going to start with the questions. Do put some questions in the Q&A and I'll feed them to the panel as we go. So I just wanted to start with Diana, if I may. I just wanted to find out what you feel are some of the biggest issues for the next 12 months, what the biggest challenges will be, and how you feel as a team in your organisation, how you're going to be addressing those.
Yeah, I think this is really important. Actually, a lot of this material was covered in Mark's talk. Actually, I think he really summed up the moral injury. I hadn't heard that phrase before, and I think that's really important. We've got sort of the strikes going to be taking place amongst our colleagues coming up, so that's an immediate problem. So I think the morale is really low, and people are tired. So we've got to get through winter. Some of the issues that we've heard about sending our cancer nurses to go and help in other areas. So we've got to get through winter, and what's happening in the NHS in other areas always does impact on us. So let's get through the winter. And we're just going to see increasing pressures. So that's an immediate problem. And Mark really covered a lot of that in his talk about how we get the morale back up. What are we going to do about our colleagues who are leaving and getting older? I'm one of those ones who's getting longer in the tooth, and I'm not ready to give up yet, but some are. And how we can be more flexible in those approaches, but we've got to be quick. The other issue is that I think in our centre, and it may be reflected in other places, is that we have got a crippling shortage of oncologists. And this is having a huge impact on the nursing workforce, both for our advanced practitioners who are making more and more autonomous decisions, without having the opportunity to escalate those. And there's some responsibility. There could be mistakes, and there could be an impact on litigious issues. But there are also opportunities. So, for example, we've recently been able to advertise for 4 consultant nurse posts within our cancer centre, which is unheard. This is just unprecedented. So I think it comes with some caution, but it can be an opportunity for our workforce. So long as we get it right, it does need some further consideration. So the caveats come with opportunities.
Great, thank you. And Claire, I wondered if you might be able to talk a bit about how, despite all these challenges, you're managing to focus on personalised care, as I know that's your kind of baby in cancer nursing.
Yes, and I think it's an absolutely essential part of cancer nursing, and delivers really the very best outcomes to people living with and beyond cancer. Whilst other professional groups may well be able to deliver important elements of the personalised care offer, I think it's a really key responsibility for cancer nurses, and one we've been working at for a good 10 years. And so it's important that we try to protect the time that we have to do that we can do it properly, and that we have the admin support to make it possible to do so. So that, the key ingredients being the offers of information and wellbeing and support, the holistic needs assessment at least once in the journey. And it's disappointing to read that the Cancer Patient Experience Survey this last year showed that just about 70% of patients felt they'd had the opportunity for discussion about their needs and concerns before they started treatment. And I'd love to see that be 100%. And I think we would get there if we knew that 100% of people had had a holistic needs assessment and then a care plan, because essentially that is a conversation about their needs, and then the care that comes from that to address those needs. It takes the whole team, of course, because it may be that they've got needs about their housing, their work, and that we need to focus on the key priorities within their cancer journey as cancer nurse specialists. But if we get it right early on, I think that really helps to offer a much more personalised care approach all the way through the pathway. You set up a relationship, hopefully then, that provides continuity of care and signposting them to the support that they need. So my kind of message out to the cancer nurses today is, if you do nothing else, think about that really important responsibility you have in trying to ensure personalised care can continue, whatever pressures you're under. Shout loud and clear, be heard that this is something that's really important that you continue to do.
Great, thank you, Claire. I've got a question, Emma, for you. Does your team have a social media platform?
So at the moment, we're hosting all our information on My Health Essex. That's My Health Essex. So you can see all our videos and cancer information there. But this is certainly something that we need to work up over the coming months. So yeah, thank you. Happy to be contacted. Yeah, thank you.
Great, thank you. Now I think this next question might be one for more, if we start with Diana first, and then perhaps Claire might want to say something as well. Looking at the broader aspect of staff retention, does anyone feel that we need to backtrack and offer overtime at enhanced rates? Agency workers should not be so significant in our workforce. They often need supervision and send stress levels sky high. We need our colleagues, and so do the patients. Nurses are leaving the NHS for agency work, which is better paid. The NHS wastes so much money in blatantly creating risk that they then waste money trying to avoid. So I suppose partly a comment and a question there, but Diana, do you have something you'd like to say about that?
This is it is interesting how this has become a problem in nursing, isn't it? And it was always a kind of problem in medicine, and now it's come into nursing more and more. It's a short term, it's so short-sighted. And I think we, in our trust in terms of clinical leadership opportunities, we're looking at how we change the culture for the whole team who makes these decisions. The operational decision making is often made between it's not sits in within nursing. It's much broader. So it involves the finance team, the operational management team, the HR team, and they don't necessarily understand the contribution that cancer nurses make. So we do need to have a much more savvy operational, broader, it's a multidisciplinary team of operational to understand a bit more about making those decisions. Because for those reasons pointed out by asking the question, it's so short-sighted. So I do think we need to address this, but it's going to take some cultural change. I would actually quite like to challenge maybe Claire in her role at Macmillan to see whether this is something they could look at addressing, some guidance on how to address this type of thing, to give some guidance, because we don't have that kind of cultural intelligence in terms of workforce across that whole decision-making team.
Okay, Claire, would you like to respond to that point, please?
Yes, I guess the difficulty for Macmillan is as a charity, we support a lot of Macmillan professionals, of course, but we don't employ them, and it does come down to that local system leadership. But that's not to say that there couldn't be some national guidance, and this probably works across all nursing specialities, not just cancer nursing. But I completely agree with you, Diana, that there is a need to be really clear what the responsibilities are at the different banding levels. I think the Ascend programme is helping with that in demarcating the competences and showing the advanced and enhanced levels of practice that are needed to work in these roles. And often an agency nurse is not going to be the solution, as has been stated here. Then the skilled nurse spends more time supervising somebody who isn't able to do the job, and it'd be far safer actually to close the number of chemotherapy beds, inpatient beds, or actually stop delivering part of the service, because we are a safety critical profession, and we need to be able to maintain our core activities. And but then I worry if we then feel that guilt that we often do about not providing the broader service, that we are going to be tempted to take on more as ourselves, that we'll burn out. And we know that we're already in a fairly perilous situation in terms of our well-being. So I think, yeah, clear role demarcation, clear definitions of what's expected in role is something we could offer guidance on, but it does come down to local level leadership.
Thank you. Claire, there's a few people here looking for some advice. So Diana, you might want to step in afterwards and answer some of these. What advice would you give to someone aspiring to become a clinical specialist nurse? And what necessary steps are needed to take to become an expert and advance their career in oncology? Where do you start?
We didn't. I was one of those who did the EMB 237, and then when that finished, sadly we lost that career pathway. And although the RCN produced the kind of career framework about 5 years ago, I don't think that got fully embedded in, and so people have found it difficult to sort of know how to become specialists in their field. And there is variation in what's expected in the role, but it would be good to talk to others in the role, particularly in your local area, and find out how they got their experience, because I do recognise it can be very hard moving from a more general environment into a specialist environment if there isn't the opportunity for you to get that clinical experience. So quite often people are developing developmental roles like the Northern Geography programme that's running, where there's a 6-month foundational programme in higher education and then 18 months of supervised practice. So it's a kind of a 2-year secondment to specialist practice. Now that's a pilot that's running over the next 2 years that's just launched, but there are other initiatives being tested. So give people a clear pathway to show how you need to get a high level of skills and knowledge within the speciality really to perform at a CNS level.
Thank you. Diana, did you want to add anything to that?
Yes, I mean, Claire's given a comprehensive answer, but individual nurses should be having their appraisals, and part of their appraisal there's an opportunity to talk about development opportunities, and raising there that might be an opportunity to raise with your line manager about your aspirations and how you might do that more locally. So yes, I think that's a very, very simple starting point. You can't be expected to have all the knowledge when you move into the development of that. And then there may be, practice really differs from place to place, but if there's an opportunity for rotation, just as described in that pilot scheme, so having opportunities to work in different places will really enhance your CV. So so if you've got an opportunity, for example, work to work in day case, as well as working on the ward, if there's, then you can move to day case and then have an opportunity to move into chemo area, then those different places will give you more rounded experience, which will make your CV really quite strong. So yes, it is about looking for talking and having an opportunity with your line manager, seeing if there's anything local, rotational, but also then looking for opportunities to move and widen your experience. And actually, just to bring in Emma here, I think it really is really important and often really good to have some community experience too. So that's my only concern about having very specialist registration. You know, I asked a question to Mark earlier, would it be nice to have a degree or a registration program just for cancer nurses? Well, we do have a lot of transferable skills if we come from other places. So actually working in primary care, a lot of primary care nurses and a lot of community nurses, district nurses and so on have a huge amount to do with our cancer patients. So that's also another area where to build expertise. So my advice to younger, more junior nurses is to get as breadth of experience in different areas, and that really will strengthen your CV.
Great, thank you. I'm going to start with Emma on the next one, and I think we'll all hopefully be able to discuss this because I think we can all identify with imposter syndrome at times. And there's a question here: any advice for someone new into a band 6 CNS role in palliative care, struggling with imposter syndrome? I just wondered if you could all maybe briefly take in turns to talk about how have you ever had that feeling, and how do you overcome it, Emma?
Oh, absolutely. I think we all go through that at, many different stages in our career. I know I have been at that stage before, and I think, especially in this role, in a Macmillan cancer role, when I have no background of working as a CNS, although the role didn't require me to have that experience, because I network and link in with those that have got that experience and expertise. So my role is very much facilitating between primary and secondary care. So I think about imposter syndrome. I think just realise, the value and worth of your role, have the confidence and the conviction in, what you're doing as a nurse. And, we're all new to this at one stage. You can't know everything. I've worked as a nurse for over 30 years, done just about every type of nursing there is to do. So cancer was new for me. So yeah, I often sort of think, listening to these fantastic speakers here today, I could easily sit here and have that feeling too. But I think it's about, be confident in what you're doing. You can only know as much as you do at that time, and give yourself that break and really utilise your colleagues and the people around you to help support you, really. So, I think it's absolutely something that, most of us have probably gone through in our careers. So, yeah, thank you.
Claire, have you ever felt that way, and what have you done?
Yeah, most definitely. You take a job and you're not going to be able to do all of it. So that's you maybe half of it. So you just keep going back to the role description, the role profile, and looking at the transferable skills. Quite easily we dismiss the things that that we don't know. We need to think, well, actually, I did do that in a different way, maybe in that job before. But keep reaching out, keep asking, and it's particularly in the early days. It's absolutely right to be saying, I don't know. When I started in this job, Macmillan's full of abbreviations, and I felt really stupid. I didn't know what they were. But you've just, you've got to find out, keep asking, but give yourself time. It's going to take months to make that transition. It's a real process, and I'd say moving into a CNS role, it was about a year before I really started to feel comfortable seeing patients on my own, and knowing that they had the skills. And I always felt quite a heavy expectation that I may not know all the answers, but actually that was fine as long as I had a good rapport and a therapeutic relationship with the patient, and they trusted me. It was okay to be able to say I didn't know something, but I'd found out where I could go and get it, and I'd come back to them, and as long as in the end they got their answer, you know, then all was good. So don't be too hard on yourself, give yourself time, keep checking back with what's expected of you, and make sure you celebrate what you are doing well.
Thank you. I'm going to put a question to Diana now, a separate question. And I know that you're doing quite a lot of work on clinical career structures and frameworks, so you might be able to answer this one best. But do you see the independent sector providing development opportunities for cancer nursing growth?
Okay, well, this is an interesting question. May I quickly go just backtrack a little bit, just to say I feel imposter syndrome all the time, and just to say that actually it's okay to not know. Just building on that one, and actually sometimes I just think, well, I don't know this, but I will find out. And the more you know, the more you realise you don't know. So it's okay not to know, so long as you recognise you don't know and you go and seek the help. And that's the key thing. Keep the patient safe and listen to them, and then you'll be fine. So that's all. So yeah, just coming back to the independent sector though. So yes, I think now we need to define what we mean by the independent sector. So I'm assuming you're talking about private healthcare. Because of course we could also be talking about more broadly about pharmaceutical industry and their roles. So on the latter, then I think they do have a responsibility, and they're already doing that, and we could probably tap into that a little bit more. I think I was involved in doing a podcast last week actually, and I think that they're a great resource often to getting the education that we need. So yes, so lots of the pharma companies do have independent educational opportunities, and that's and yes, look out for those, because they're often really excellent because they can put in resource that we can't do. So that's an opportunity that we can tap into. In terms of private healthcare, well, I think this really differs geographically, so it may be much more of a thing down in the southeast. You know, there is private healthcare up in here, but we're in the South Yorkshire, one of the most deprived areas in England. So we do have some private healthcare, but it's not in competition particularly with what we're doing. Yes, I'm guessing so, but I really don't have much experience about that. I guess we ought to be considering partnerships in a way, and looking at working with what different partners can offer and what they can bring to a table to benefit all healthcare professionals wherever they work, to look after our cancer patients.
Great, thank you, Diana. While you're speaking, I've got someone who's, I think, seeking some advice. We talked earlier, and it was Mark's speech. He was talking about flexibility, helping address some of the workforce issues. This nurse has been given flexible retirement, that's been agreed, but they're expected to carry on with much of the workload for reduced hours. How do we try and negotiate that?
Yes, so I think we've got to learn to be a bit more savvy about this. I read this really interesting article in the Journal of Advanced Nursing a few months ago about being nice in nursing, and how as nurses we care and we tend to be polite and nice, and actually it's not about not being nice, it's just about being assertive and challenging. And actually if you're still keeping the same workload and it's unreasonable, then that needs to be challenged, and it can be done so in a reasonable way. So if you're reducing hours, I would be looking at a job plan and looking at what a reasonable work amount that is, and looking at the ratios and being reasonable about what kind of patient load you can take on. And if there is, you can only do so much, so I wouldn't be agreeing. And if you can't get that reasonable, there should be a lead cancer nurse or someone where you can sort that out, and getting a load, getting a conversation that's just really a reasonable conversation, perhaps involving your medical colleagues as well, then sitting around the table. And if it can't be resolved, then ultimately you probably need to go to your union to sort that out. But hopefully you can take a few steps before that to sort it out. But it would sound on the face of it unreasonable to be doing the same workload in reduced hours. I think you would need to look at a job plan and looking at your patient load and having a discussion about that.
Great, thank you. Claire, if I could just bring you in, I've got a question here, Macmillan one. We have a Macmillan support worker who completes holistic needs assessments, but with some patients. Can you recommend a framework for nurses ourselves to follow when treating patients?
A framework for the holistic needs assessment,
Needs assessments, yeah.
There's some really good materials on the Macmillan website, and there's some super resources online in terms of sort of going through. I mean, the questions themselves, the holistic needs, are the framework in a way to have it in the conversation. I think that if that's answering the question, but it maybe are they saying for themselves as a CNS?
They're saying they'd like to be recommended a framework for themselves to use when treating patients. So
I think it's probably what then comes out of that conversation. So, you know, the main concerns are often anxiety, fatigue, pain. And so it's possibly the questions about how you then manage those and where you might sign people to. So, yeah, I think there are some really good materials online. I would suggest the Macmillan website as a first port of call. Other cancer academies like Guy's Oncology Centre have got a really good personalised care module that's free that you could link into. But hopefully you'll find the resources. If not, get in touch.
Okay, and there's a question here about HNAs again. Are any clinical nurse specialists using electronic holistic needs assessments within their trust? Obviously, you won't know for every trust, but do you get a sense that most of them are?
I hope so. I mean, that's our kind of desire because the data is easier to interpret and sophisticated. The outputs are very professional in terms of how they're templated back to the patient and the GP. I think we're doing nationally about 4,000 EHNAs a month. So although in terms of completed care plans, that's only 17% of the cancer population, a huge number of EHNAs are being completed. A lot of trusts will have different platforms for use, like Somerset or Infoflex, but they do now link in with the EHNA.
Thank you. I've got a question I'm going to put to Diana next, and I wondered what your thoughts are on tumour site-specific clinical nurse specialists in supporting oncology clinics instead of oncology clinical nurse specialists doing this. We became more involved in these clinics when oncology CNSs left and weren't replaced. Is this commonplace?
I can only answer for my centre, and we haven't done that. So we've got site-specific, tumour-specific clinical nurse specialists. So without knowing the details, I wouldn't be able to answer that specifically. I could see some there's pros and cons to everything. So you may not get the specialist, but there are some transferable skills between them. And I guess it depends on the size of the cancer centre and how many they're treating, because of course if you're at a DGH with a smaller workforce, it might make sense to do that. So yes, I can't answer specifically. I haven't seen that happen, so I can't draw an experience. It might be something that Claire knows more about than I do.
Claire, did you want to say anything on that?
And I'm thinking we've thought a lot about secondary care, but as we see, I think more roles are going to be developed in primary care, and we do need to think more broadly about how we can support people who have not just cancer but other long-term conditions, and making sure that the people have the skill set to kind of cope with that. Maybe Emma would like to comment on that, but there's a place for it, but making sure that caseload is manageable and people have the skills and capabilities to support the patient group that they're assigned to.
Brilliant. Emma, if you'd like to say something.
Yeah, understandably there has been a focus on secondary care, but my experience obviously from primary care and working with practice nurses, we've been linking in with the CNSs and the cancer support workers at our local trust, and trying to increase and improve the number of cancer care reviews that are done in primary care. So typically a patient would have their HNA done in secondary care, and they would expect, and hopefully now, to see cancer care review at 3 months and one at 12 months. That's part of QOF, Quality Outcome Framework, and it's something that's been introduced in primary care. So We're training more nurses up in primary care to deliver the cancer care reviews. And we're seeing a lot more of the extended roles, what they call the R's roles, so the paramedics, physiotherapists, pharmacists now working in primary care. And some of these healthcare professionals as well are, you know, really taking part in medication reviews and cancer care reviews for patients. So whilst a huge amount of work is happening in secondary care, it's just to point out that, you know, in primary care as well, it's sort of about linking that up, joining up those dots so that patients see more of their primary care healthcare professionals. We know from the cancer audit and the surveys that patients are saying that they haven't seen. You know, we want to encourage them to come forward and see their healthcare professionals within primary care. So by doing more training around cancer care reviews, we're hoping to see that visibility, and then for patients to be able to get that support, you know, after treatment has finished. And quite often, anecdotally, that's just when you need the support more than ever.
Great, thank you. We've got a few more minutes left before I draw this to a close. Mark is in the chat saying that they use electronic EHNAs every day. So that, yes, well done, Mark. That's good to hear. So I've just got a couple of questions, and if anyone else wants to feed some more through, please do. I just wondered if I could find out from you, Emma, about trying to bring in patients and patient involvement. Obviously, there can be some drawbacks to that, as well as obviously there's a big drive to get patients more involved in making decisions about their care. What do you think are the greatest challenges and hurdles to doing that, and are there some limitations involved?
Yeah, absolutely. Good question. So for us, when we put One Step at a Time together, obviously it sort of started with my experience and my own story. And then later we brought in the experience and story of others, and it became our journey. So what you will find, and what we actually did find, is, well, people would say, well, that wasn't my experience, or, you know, that's not how it happened for me. So slowly but surely we will start to bring in more perspectives of different people's viewpoint, you know. So you will find that everybody has a different experience, sometimes very positive, other times not always the case. So yeah, I think they are some of the challenges, and trying to have everybody's viewpoint, bring that in collectively, and then say, right, now this is the point where we actually need to bring this together. And, you know, otherwise, if we just spent lots of time talking about it, we would never have actually put these videos and information together. But yeah, we absolutely listen to the voice of our patients. It's them at the heart and centre of what we do. But we are a group, and we just try to work collaboratively. So I think that that's probably some of the challenges we found. But we respect each other's opinions, and you know, I think it says everything, really.
Great, thank you. I think really that we've got time for one more, and I just wanted to ask Claire and Diana whether they could just, in a sort of 60-second soundbite, say, is there something that trusts should be doing now themselves to try and come up with new clinical career frameworks, or should be waiting for national direction on this? Diana.
Okay, well, there's a lot to sum up in a minute. So I'm going to focus on the CNSs. I think our CNSs have been sort of overlooked over the last 3 or 4 years, particularly with the advent of getting the ACPs up and running. The ACPs are an important part of the workforce, but unfortunately, I believe the CNSs have been neglecting it as a result. We've got, you know, a huge faculty of ACPs, lots of training, it's all set up. We know exactly the competences and so on that they should be doing. And I actually would like to see a similar amount of energies going into looking after our CNSs, educating them exactly, you know, not that they don't need to be doing the same thing, but the same amount of attention and needs to be given. We've got, from all the reasons Mark pointed out, we need to be looking after them, we need to be developing them, and we need to be making sure that we've got a route in as well as that route out. So yes, I think the CNS deserve that, but it's the route in. So that's looking at the junior end as well, and how we get those up and running, have much more expectation about standardization of what to expect from our CNS roles across the country. And that's really what I would like to be seeing over the next 2 or 3 years.
Great, thank you. Claire, is there something you want to add just very briefly?
Well, completely echo everything that's been said, and I think also the CNS force is such a difficult stage at the moment with a number of vacancies. It's absolutely vital that we support, promote, retain those that we have, but then we look immediately to how we're then going to find our next workforce, and it is about providing those opportunities for development, and the national guidance is going to be really critical on this, and it will provide the training opportunities that are needed. Because this is a highly skilled role, and I think we need to just keep telling, any manager who's asking for another CNS review, what is it that you do? I don't really understand it. That this is a advanced role that has leadership, education, service improvement, research, evidence-based practice kind of components. It's a really critical to delivery of cancer services to have your CNS supported and fully functioning, and there shouldn't be any need to question the value, because there is so much evidence already out there supporting not just the difference it makes to patients' quality, but also cancer service outcomes as a whole. Brilliant. So value your CNS.
Brilliant, thank you. Sorry to keep it so short, but we're running out of time now, so I'm going to bring this to a close. Thank you very much to everyone for attending. So much to cram in as always, and thank you for all the speakers for such great presentations. Lots of tips and ideas for bringing innovative practice to your daily roles, and really great to hear, I thought, about some of the positives in this, really, that we can shift our perspective. There is a lot there to also look forward to, some really exciting projects. It's not all doom and gloom. So the certificate of attendance, that will be emailed to you shortly. I think there's an email there, eventsupport@rcni.com, and you should also receive the recordings of this for those who couldn't attend, as well as those who might want to watch it again. The talks have been great. I hope you all are left feeling re-energized and full of ideas for putting into action in 2023. And if you wish to be involved with the journal in any way, to be either a peer reviewer or maybe you'd like to write for the journal, please contact me, jennifer.sprinks@rcni.com. Give me a follow on Twitter @rcni_sprinks. I think that covers everything. Sorry to rush, but please do keep in touch. And in the meantime, wishing you all a very happy Christmas and a really great 2023. Thank you.